Hello, I am Juan Plana. I am the chief of the cardiovascular service line at Baylor St. Luke's Medical Center in Houston, Texas. I want to start by thanking Dr. Stephanie Coulter for giving me the opportunity of being part of this very important 12th annual Women's Heart and Vascular Symposium. She has asked me to talk about a topic that is part of our day-to-day operation, which is the timing and intervention of the female patient with aortic stenosis. I came across this perspective article written by Dr. Eugene Bromwell about the then and now of aortic stenosis, where he starts by reminding us of this graph with this curve that all cardiologists are familiar with, that he produced along with John Ross in the 60s. And in this curve, he tells us that the patient that has aortic stenosis goes initially through a latent period where there is increasing obstruction and myocardial overload with a minimal change in survival. And then you have what they call the break point, where the survival decreases in a significant fashion once the patient starts having symptoms. And then you're going to have an average survival of 2 years if you have shortness of breath or symptoms of heart failure, 3 years if you have syncope, or 5 years if you have angina. But I want to bring to your attention the average age of death for this population, that is 63. And what they remind us in this perspective is that the type of patients that they were dealing with or that they were writing about were patients that have rheumatic aortic stenosis, hence the age of demise. These are not the patients that we are dealing with right now. We are dealing with patients that have calcific aortic stenosis, and usually these patients start getting in trouble exactly at that age, in the 60s, going from the 60s to the 80s. So it is very important to remind ourselves that still the presence of symptoms is the strategy that we look for to decide on when to intervene on these patients. So let me remind you of the new classification that was used in the American College of Cardiology, American Heart Association. They created 4 different stages. Stage A, the patient at risk of aortic stenosis. Stage B, which is what we used to call mild or moderate AS. And you have stage C, your asymptomatic severe AS, and stage D, your symptomatic severe AS, with D1, D2, and D3. D2 is your normal flow, high gradient severe aortic stenosis. D2 is your low flow, low gradient severe AS with reduced ejection fraction, the traditional low flow, low gradient. And D3 is your low flow, low gradient severe aortic stenosis with normal ejection fraction, which is what in the past we used to call the patient with paradoxical low flow, low gradient severe AS. Over here, we have a figure 3 from the guidelines from the American College of Cardiology, American Heart Association. And the first question that the guideline asks you is, do you have symptoms, yes or no? So if you have symptoms and if you have a peak velocity of more than 4 meters per second and you have a mean gradient of more than 40, you need to intervene in the form of SAVR or TAVR. Then if you have a Bmax of less than 4, but you have an aortic valve area of less than 1 centimeter square, then the guideline asks you, is your ejection fraction less than 50, yes or no? If it's less than 50, and if you use dobutamine, and if you're able to generate a maximum velocity of 4 meters per second, then you are in what they call the D2 stage, and they recommend that you proceed with surgery or TAVR. If the ejection fraction is not less than 50%, then you are in the presence of what they call D3, as long as you're able to demonstrate that you have an aortic valve area of less than 0.6 centimeter square per meter square, and then a stroke volume index less than 35 mLs per meter square. Then if you go to the right side, if you do not have symptoms, then the guideline asks you is your ejection fraction less than 50%? So if that's the case, then it allows you to go for an intervention. If you're going to do another cardiac surgery, just like it happens if you are with a moderate aortic stenosis, it allows you to do intervention. And then you have two strategies for taking the asymptomatic patient. Either you have a situation where the asymptomatic patient has a pretty tight aortic stenosis with a Vmax of more than 5 meters per second, or if you have a rapid disease progression, or if your BNP is 3 times the upper limit of normal, or the other possibility is that you will prove that the patient is actually symptomatic, or that you have reduced exercise capacity or a drop in your blood pressure when you put the patient in the treadmill. So I want to review with you a couple of cases so that you can realize that it's not as straightforward as the guideline looks like. These are cases from our institution. So the first one is a 95-year-old female that comes very symptomatic with bad shortness of breath, and the assessment of the aortic stenosis in the echo lab and in the cath lab looks like this, with an aortic valve area of 1.1 to 1.18, and with a peak and mean gradient of 49 and 31, and a peak of 25 by the Hackey equation. So the case gets presented in our TAVR conference. Everybody makes the statement that this is moderate aortic stenosis and that this patient will not qualify for a TAVR because the guidelines will not recommend that. Nevertheless, the interventional cardiologist explains to the group that the patient is very symptomatic and that he's convinced that aortic stenosis is responsible for the symptoms of the patient. So I keep on asking questions, and we end up checking for the ejection fraction. And as you can see over here, it looks like it's a hyperkinetic, hyperdynamic ventricle. There is some evidence of mitral annular calcification. You see over here the valve, and looks like the valve is calcified. And then we end up asking simple questions. What was the blood pressure in the moment that the patient was in the echo lab? And the blood pressure was 200/79. And when the patient was in the cath lab, the blood pressure was 174/64. So what we end up doing is we agreed to treat the hypertension and to bring the patient back to the echo lab for assessment. So in this particular case, we were able to bring the blood pressure from 200 to 152/66, and you are able to see peak velocity that is at 4 meters per second around that, with a peak and mean of 71 and 42 millimeters of mercury, letting us know that we are in the presence of a stage D1 and that the patient needs to proceed with TAVR. In this particular case, this was the global longitudinal strain, so as you can see, is normal. And I want to show you something that is important in these patients with aortic stenosis, that is the calculation of the ZVA, or the ventricular arterial impedance. So what you do is, in the numerator, you are going to put the systolic blood pressure and the mean gradient, and in the denominator, you're going to put the stroke volume index. As a principle, what is going to go in the denominator are in the numerator are the forces that are going to oppose the ejection of blood. So you have a systolic blood pressure of 200 and the mean gradient of 31, and in the denominator you're going to have your stroke volume index, which is how much blood is able to put forward despite the impedance. So in this case it's 4.94. And as you can see over here, once the patient was treated, the impedance goes down to 3.71. Now, in this particular case, the GLS was minus 26.6. The ZVA went from 4.9 to 3.7. But the question is, do these numbers have any implications? And we have this nice article from my former team at Cleveland Clinic, where they're able to demonstrate that these two parameters have prognostic capacity in terms of freedom from death. You have, using a cutoff of minus 14.9, 14.5 rather, on the left, freedom from death. So if it's more negative than minus 14.5, you're going to have a relatively normal survival. But if your GLS is abnormal, letting you know that that ventricle is suffering, then your mortality will be compromised. And then to the right, you have a ZVA using a cutoff of 4.5, very similar ability to prognosticate. Case number 2, it's an 80-year-old male status post TAVR, but the same principle applies for a female patient. And in this case, the ejection fraction is 45 to 49%, severe left ventricular hypertrophy. You have a low flow. I mentioned to you before that the cutoff for stroke volume index is less than 35 cc's per meter square, and you have a low gradient as a result of that, but you have an aortic valve area of 0.75. Your dimensionless index is 0.22, with evidence of a pulmonary hypertension and a small pericardial effusion. Although you can see pulmonary hypertension in patients that have aortic stenosis, this is not frequent. Usually it's around 20 to 25%. And the other thing that gets your attention is the presence of a small pericardial effusion, which usually we do not see in the setting of aortic stenosis. So I am reading the echo after the TAVR, and I get the impression that the ventricle looks thick, that is very sparky in appearance, that it's got what we call the specklish pattern or a starry sky appearance. And immediately I get concerned about the possibility of a cardiac amyloidosis. Then we end up using global longitudinal strain, and we are able to demonstrate a very abnormal strain at the base and in the mid segments with preservation at the apex. You see this in the apical 3, in the apical 4, and in the apical 2-chamber views. And in this case, this is the way in which we interpreted. The GLS was extremely abnormal at minus 7.9, and we say that there was evidence of apical sparing pattern or cherry on top, suggestive of cardiac amyloidosis, and we recommended a PYP scan to rule out transthyretin cardiac amyloidosis. This was the result of the Technetium pyrophosphate scan, diffuse activity throughout the LV and more regional uptake within the RV, and it was read as findings that were typical for TTR cardiac amyloidosis. You see over here from our publication, so you have A1, A2, A3, and A4. Those are cases of cardiac amyloidosis. You see the apical sparing pattern. B1 and B2, the abnormality is really at the level of the septum, anterior and inferior septum, and those are patients that have hypertrophic cardiomyopathy. And C1 and C2 are patients that have aortic stenosis. You're able to see that although the apex is compromised, there's also compromise of the basal segments, which you do not, the strain is normal at the apex and also at the basal segments. And when you take a look and when you compare them with A1, A2, A3, and A4, you do not see any evidence of normal strain in the basal segments. So what are the conclusions of my talk? The decision to intervene is based on the presence of symptoms. You need to consider doing an exercise stress test to elicit symptoms in your patient that has severe aortic stenosis and that is telling you that is asymptomatic. You need to be mindful of the effect of hypertension on your AS hemodynamics, and you need to remember in the patients that are older than 80, when you are seeing a paradoxical low flow, low gradient, severe aortic stenosis, this is cardiac amyloidosis, TTR amyloidosis, until proven otherwise. Thank you so much for your attention, and again, thank you so much for the invitation.